Welcome, I'm the dentist. In our DENTAGENDA, we will be continuing the first chapter, History Taking and Examination, Part 6, Differential Diagnosis. These are the points included in this chapter video series. And here is the detailed content. Today's topic is differential diagnosis and treatment planning. Arriving at this stage is the whole point of taking a history and performing a series of investigations and examination, because by narrowing down your patient's symptoms as possible, in most instances will formulate the diagnosis and treatment plan that will benefit your patient. Differential diagnosis is a serious step in your diagnosis because important and serious conditions can be overlooked. So, it is based on exclusion, and any lesion that cannot be excluded represents your initial differential diagnosis, and then it's the base of your ordering tests and procedures to narrow down the possibilities. Depending on each and every information you've gathered, you should link them together, just like a puzzle pieces. That will lead you to the correct diagnosis. I recommend you watch this chapter video series in which all diagnostic techniques are illustrated. Today's tutorial is about differential diagnosis. In this tutorial, you shall learn some important guidelines in case of odontogenic pain that arises from the tooth or its supporting structures, or non-odontogenic pain that arises from other orofacial structures. Start with the odontogenic pain. Firstly, you should know that odontogenic pain that arises from the tooth or its supporting structures can be pulpal if it originates from the pulp itself, or it could be a non-pulpal pain that originates from any of the supporting structures around the tooth. Odontogenic pain that is pulpal in origin. Starting with, in case of healthy pulp, healthy or vital pulps will respond to any stimulus, whether cold or hot, and the sensation of the pain due to its stimulus will not linger. It will disappear right after the stimulus is removed. Dentin hypersensitivity. In case of exposed dentin, like in cases of attrition, abrasion, abfraction, or erosion, that exposed dentin will produce some sort of a sharp pain due to chemical, thermal, or tactile stimuli. Learn more about these differences at DENTAGENDA on Instagram. Caries. Dental caries that extends into the dentin or pulp can be stimulated by anything, whether hot or cold stimuli, on biting and percussion, and with sweet or acidic and sour foods. Radiographic and clinical examinations will confirm this diagnosis. Reversible pulpitis. When we say reversible, we mean that the pulp can be restored into its healthy condition because the injury is mild. The pain resultant is provoked and not spontaneous. The pulp is still sound. It is not infected nor exposed. It is just inflamed. But when the stimulus or the local irritant is removed, the inflammation ceases and all the symptoms will abate. This can happen in cases of caries or micro leakage under restorations. Unlike reversible pulpitis, irreversible pulpitis means that the pulp tissue cannot be restored to its healthy condition because the injury is severe. The pulp in this case could be exposed or infected with microorganisms. The resultant pain is spontaneous and it lingers even if the stimulus is removed, like cold or hot stimuli. The treatment here requires root canal treatment or, in worst cases, extraction. Percussion and palpation sensitivity indicates that the inflammation is extended to the periradicular tissues and it may start an abscess formation. Number 6. Pulp necrosis, meaning that the pulp has lost its vitality. Pulp necrosis has two distinct presentations. One could be symptomatic and the other is asymptomatic. In case of symptomatic pulp necrosis, the pain is a throbbing pain and it is spontaneous. No response to any thermal stimuli. The swellings resultant from the pulp necrosis could be localized or diffused. Palpation sensitivity and percussion sensitivity, meaning that the inflammation has extended to the periapical tissues. The radiographs can sometimes show periradicular pathology and bone resorption. The other form of pulp necrosis is asymptomatic pulp necrosis. The main difference between symptomatic and asymptomatic is that, in this case, the tooth is completely not responsive to any thermal stimuli or electric pulp tests. Sometimes it can be accompanied with a fistula on the buccal or lingual surfaces of the mucosa of the affected tooth, and the radiographs indicate bone loss and pathology. Pulp necrosis can be presented with many clinical ways, like localized or diffused swellings, bulb polyp, fistula related to the tooth, and tooth discoloration. All of these means that the pulp is necrotic. Find more about these cases at DENTAGENDA on Instagram. Number 7. Temporomandibular joint disorders and cracked tooth syndrome. The cause of any TMD or tooth crack can be due to parafunctional habits like bruxism and clenching. The symptoms that accompany these cases are a combination of odontogenic and non-odontogenic myofascial pain related to the muscles around the TMJ, a sharp shooting pain on biting, and a delayed or lingering cold sensitivity is often reproduced. Number 8. Complete vertical root fracture. The treatment of this case is hopeless, and that's why its right diagnosis is crucial. Diagnose a complete vertical root fracture is mobility. You can use the handle of an instrument and try to move the parts of the suspected tooth. If there is a complete root fracture, the two parts will freely move separately. Another way is transillumination. Transillumination means that you use light against the suspected tooth and darkens the area around the tooth. You can see here that the vertical crack is visible and that extends along the root. Also, the use of methylene blue dye can help to detect any cracks in the teeth, whether it extends into the enamel or it extends into the dentin as well. Sinus related to a tooth, that most probably means that there is an infection beneath that tooth, which can be a result of vertical root fracture. You can explore a deep pocket that drops down to the apex, It definitely means that there is a vertical root fracture, since the attachment is lost along the fracture line. Surgical flap can be used as a last resort to see if there is a vertical root fracture before you can decide to extract the tooth. Radiographs, which we will discuss in depth. For radiographic diagnosis for complete vertical root fracture, know that if the root fracture is associated with a necrotic pulp that is symptomatic or asymptomatic and periradicular bone loss, it can most probably be misdiagnosed as an alveolar abscess. The dentist, in that case, would probably suggest that the tooth needs an endodontic treatment. The therapy will fail because the root canal treatment will not seal the leakage along the fracture line, and in that case, the mistake is a diagnostic mistake, not a treatment mistake. Number 8. Radiographs. Know that the angulation of the X-ray beam and the degree of separation of the fractured parts or fragments of the root will determine how easy it is to use radiographs to diagnose root fracture. If the root fragments are shattered and separated, the fracture will be visible on the radiograph, like in case of horizontal root fracture that can easily be seen. Vertical root fracture, where the separated parts are mesial and distal fragments. In this photo, the fracture is associated with an endodontically treated teeth, and that suggests that the filling was done under extra force. Also here, there is a vertical root fracture, and that is associated with a wrong placement of a metal post. In case of no separation, or if the fractured segments are a buccal and lingual parts, the diagnosis, depending on the radiograph, will be challenging. Instead of depending on the radiograph to see the fracture line, you will depend on the radiograph to see the consequences of the fracture. Other signs that you can depend on to determine that there is a vertical root fracture from the radiograph other than seeing the fracture line. Firstly, a rapid destruction and bone loss around the affected root. Unexpected bone loss in the furcation area of molars. A J-shaped bone lesion and resorption. That are associated with vertical root fracture are mild pain on biting on a tooth sleuth, swelling in the gingival tissue associated to the affected tooth. As you can see here, there is a fracture line that extends down to the root. Drainage through the sulcus. The tooth might feel high by the patient, and the formulation of root fracture fistula. To differentiate between different types of fistula, check DENTAGENDA on Instagram. The odontogenic pain that is not pulpal in origin. Non-pulpal odontogenic pain can be endodontic, periodontal, or occlusal in origin. Any of the three can exist alone or can be a primary, secondary, or tertiary cause of the odontogenic pain. Idiopathic invasive external root resorption. It is unclear what initiates this process. External root resorption often mistaken for internal resorption or decay. Trauma is frequently associated with external root resorption, as in case of traumatic and invasive orthodontic treatments. External root resorption is a disease of the attachment apparatus. The problem is not the pulp. Unlike internal root resorption that can be treated and stopped with root canal treatment, external root resorption cannot. External root resorption is usually asymptomatic, yet it can sometimes be painful, as much as pulpal exposure when it perforates into the pulp chamber. Number 2. Periodontalgia. In that case, you can see an abscess related to the attached mucosa. It is not as painful and throbbing as the acute alveolar abscess that is endodontic in origin, but frequently it is asymptomatic, and the diagnosis here will depend on the clinical and radiographic examination. Other characteristics of this disease are gingival inflammation, tooth mobility, localized bleeding, and measurable bulkhead depth. To learn more about tooth mobility, check this video, Dental Investigation. In case of periodontalgia, a horizontal and vertical bone loss from the cemento-enamel junction down to the root surface can be seen in the radiographs. It appears in varying forms, locations, and degrees. To learn more about that, check DENTAGENDA on Instagram. Reproducible sensitivity to temperature and pressure due to the exposed cementum. Affected teeth might experience biting and percussion sensitivity, especially if there is an inflammation by an impingement from a restoration. Pericoronitis. It's a painful gingival condition that can be misdiagnosed as pulpal in origin. Pericoronitis exists when the operculum, which is the extended part of the gingival tissue on the occlusal surface of partially erupting molars, become infected or injured. The patient may experience trismus and discomfort during opening and closing, and the operculum itself is acutely painful to touch. And sometimes it can be a big problem when the patient bites by the opposing tooth on the operculum. The inflammation in that case becomes exacerbated. Number 4. Occlusal trauma. Occlusal trauma occurs when there is any excessive forces applied to the teeth, whether it's because of a parafunctional habit or prematurities or a high restoration. Pain, tenderness, and cusp fracture and incisal edge wearing and abfraction and mobility can all be results of occlusal trauma. Not balanced occlusal relations between the opposing arches can lead to alveolar bone loss, horizontally and vertically. In conclusion, differential diagnosis starts with thorough history, examination, and investigation processes. At least one confirming reproducible test is necessary to make a diagnosis of odontogenic etiology. If the radiographic and the clinical examinations are all within normal limits, then you need 2 confirming reproducible tests, not 1. All dental diagnosis is demonstrated in the interrelationship among the pulp, periodontium, and the occlusal forces placed on teeth. These can lead to pulpal and non-pulpal odontogenic pain. If all are eliminated, then non-odontogenic etiologies must be considered, and that's what we are going to discuss in the next video. Thank you. Don't forget to subscribe and join us on YouTube. And also find us at DENTAGENDA on Instagram for extra tips and tricks.